next really cool session. And turn this off. So, you know, we all know that policy can drive innovation and new business. So when Claudia from the White House reached out to us about presenting here, I thought, you know, how amazing to have them come present at and talk about their vision and their plans for CES. So, and programs that they have going. So I'd like to welcome Claudia Williams. She is the Senior Advisor from the Office of Science and Technology Policy at the White House, to the stage. Thank you. Oh, wait, one thing I forgot. Her New Year's resolution, oh my. She wants to create more time to think. Thank you.
Hello. Now it's really on. Hey, before I get going, I would love to just get a better sense of who all of you are. Raise your hand if you are with a tech company, a company that makes tech products. Awesome. Raise your hand if you're a clinician or a provider of some sort. All right. Raise your hand if you're a trade association, journalist. Who would I leave out? Consultants, of course. Okay, great. Awesome. How many people are from DC? Okay, great. It's so great to be here. I was messaging my 17 and 20-year-old all day to try to get some kind of feedback on what I was seeing, especially in the gaming section. And I have to say, it's phenomenal to see the tech potential throughout the displays that could ultimately be leveraged for healthcare, and not just wearables, but every other manner, especially the smarter home area. What I wanted to do, just briefly, understanding that I am the last person of the day and standing between you and hopefully a really fun evening, is first of all talk a little bit about the Chief Technology Officer's office within the White House. Second, give you a snapshot view of the changes we're seeing in healthcare at the 10,000-foot level. Third, talk about some of the specific policy actions that we are most excited about. And then talk a little bit about 2015, both from the perspective of things we're working on and some insights and observations for all of you. So, the Chief Technology Officer's office within the White House. It's headed by Megan Smith, formerly of Google. I have other colleagues such as Alex McGillivray, who is the policy director at Twitter. So we are a very small skunk works kind of office within the White House to be the advisors on innovation and technology for the president and for agencies. And so, for instance, after healthcare.gov, the website wasn't going so well, and we were bringing tech talent in to help fix that. That really inspired a whole wave of tech recruiting from some of the largest and most innovative countries in the nation, really headed up by our office to see if we could get CTOs and chief data officers in every single agency to be working on important and critical issues facing our country. Second, tech policy. So things like net neutrality, open data, in healthcare, payment rules, data rules that affect all of you. So we are both an advisor, but also kind of a galvanizer and instigator within the White House. Very small. We're about 10 folks right now. But we do a lot of interaction and reaching out to folks like you in the technology and innovation community. So you are all in the trenches doing your work. And one of my old colleagues, Farzad Mostashari, I was working a lot on health information exchange, which was a grueling and difficult area because, let's face it, until we have motivation to exchange through new payment, it's quite hard to get it going. But what he would always say is, listen, it's really tough today. And you're feeling the pain of all of the dead weight and how hard it is to evolve healthcare. But look back a year and observe the incredible changes that have occurred in just 1 year. So let's just take stock of where we are today. Readmissions down 130,000 people. Health-acquired infections, hospital-acquired infections, down 17%. That's 12 billion of savings. Healthcare cost growth is at its lowest in 50 years. And for the first time, we have an incredible driver of consumerization in healthcare because individuals are picking their health plans through the exchanges, and lots of people are on high deductible plans. So it is clear that critical things are shifting and changing in healthcare. And what have been some of those drivers? And these are things you work on every day, but let's just take stock for a minute of what they are. When President Obama took office, 1 out of 8 hospitals used an electronic health record. By 2012, that number had tripled. So in 4 years, the number of folks using electronic health record had tripled. This year, in June, or last year, in June of 2014, we had more than 75% of doctors and more than 90% of hospitals participating in the Meaningful Use program. Now, there's a lot of questions about what the future of that program should look like. But we now have a digital platform for healthcare in the use of digital tools in the doctor's office. The same is happening with patients. These changes have occurred in just a few short years. We have a digital dial tone across America connecting clinicians. We have to make good use of it, yes, but that is an incredible change. Also, when the president took office and when the first chief technology officer was named, Anish Chopra, who I guess is here today, I see him on Twitter, the idea of these vast amounts of data that government collects, that your tax dollars pay for, going to good use and being used for new products and being released in the open in machine-readable, open forms was really leveraged and galvanized under him, and then following that by Todd Park and now by Megan Smith. We've had more than 140,000 data sets released. Now, you might think, data sets released. Think about it, all of the weather data that we use for all of the consumer products for projections and forecasting, that's NOAA. GPS, that was created by the government. Labor statistics data, right? Medicare data. These are incredible engines of growth and use for all of you and your companies. In last year, the president issued an executive order and he said, from now on, I'm turning the default to open. New data sets that are created, we will release them unless there's a privacy concern, and they will be available in open machine-readable ways. API is the future, default to open, incredible engine of growth and change. In addition, and importantly, we've had many payment reforms from ACOs to bundles to readmissions penalty to never events to the new chronic care payment that Jim mentioned just recently, that are all driving change and improvement in healthcare. We are no longer suffering from the tyranny of fee-for-service medicine. So looking forward to 2015, what are we thinking about in the White House and the Chief Technology Officer's office related to health and innovation? So first of all, and this is something that there's a great deal of interest, even from the president on, we need to make good on the promise of precision medicine. Now, you might say, that's a Rorschach test. What the heck are you talking about? What we're really talking about is the ability to inform tailored medical treatments for patients, drugs that will actually work for your given genetics, your given composition. But to do that, we're going to have cohorts of patients and data like we've never had before. We're going to have to knit together claims data, clinical data, device data, sensor data, genomics data. And we're going to have to do this kind of research in a way that is very different from the past. Patients are going to be driving and asking for this. They will be donating their data. They're going to be helping shape the agenda. This is no longer the case of I sign up for a clinical trial and, oh, by the way, a good drug might come out later. We have a very different dynamic that we need to create and really get going. More data, more open data. So what's on the horizon there? Well, I don't know if you were paying attention, but the recent rules that were released on the exchanges asked all of you whether it would be a good idea for the marketplaces to release machine-readable data on formulary and on provider networks for every single marketplace plan. We hope that folks will jump to this opportunity. Imagine if you could have a consumer tool which alerted you to which plan you should enroll in, where the closest doctor was, and what the cheapest drug might be on your formulary. Those would be incredible tools. Now, we hear often from doctors and hospitals that in this time of incredible change, especially for payment reform, they are suffering with one foot on the dock and one foot on the boat. They don't know which way to go. On the one hand, they have to survive and thrive in fee-for-service medicine. On the other hand, they are moving towards a new world where they'll pay for outcomes and not for services. This is especially acute as a problem for the small docs who don't have much margin. They don't have an ability to invest in big capital, big data platforms, new kind of ways of doing things. So to address this concern, a new program was announced a few months ago that would devote $840 million to supporting physicians in making the transition, finally, to a form of medicine that doesn't just take place in the office, but is going to support patients in their homes. The chronic care payment that Jim talked about is huge. One of the analyses I saw said, if you're able to provide this kind of care, remote monitoring, ability to manage medication adherence in the home, elsewhere, transitions of care having information flow for a doctor with lots of Medicare patients with multiple chronic conditions, that might be worth $200,000 a year to you. So your work is going to be critically important to make these things succeed. But to do that, we have to have folks like you and doctors and hospitals and patients communicating much more deeply with each other than I've seen in these marketplaces in the past. What are some of the two other areas that we're really interested in this year? One is interoperability. And again, this is sort of a Rorschach test kind of term. But especially we're interested in having the clinical data in the EHR be much more broadly available to a health IT ecosystem. What would it look like if there were actually open, standardized APIs from the medical record that could go into consumer-facing tools, could go into analytics engines, clinical trial discovery, all kinds of things. And that's one of the areas that's being considered for the next stage of meaningful use. Finally, innovative regulation. So we've heard a lot about this tension between, on the one hand, protecting consumers, and on the other hand, allowing for innovation through FDA and other policies. We're really interested in hearing from you. Where is the right line there? How can we better enable innovation through the approach we take to innovation? Is there a potential to have test beds before something, if you want to propose something, you don't know yet exactly how it's going to turn out, but you want to be able to interact with patients? How can we create safe zones for innovation? How can we create regulation that that holds back on the lowest risk items like the FDA did with their mobile medical apps guidance? So finally, I want to leave you with some reflections as I've been walking around the show hall and talking with many of you. What words of guidance would I give? And I'm hoping I'll receive some from you as well, both here in the session and afterwards. One is that we really need data and evidence about the impact of the tools you're developing on the outcomes of care. We so deeply need that. And I know you're hard at work developing that. But all of the hard work we're going to do to sell these products to policymakers, to sell them to health plans, we desperately need hard evidence. And it could be hard evidence. It doesn't have to be an actual health outcome. It could be engagement. It could be adherence, right? But we need you to come forward with data that demonstrates that your products work. To do that, we're also, I think, going to need much more thoughtful ways to bridge between tech innovators and the clinical environment. So an example I like to talk about is Dignity Health has a program called Greenlight that brings in often startup products into the clinical environment and in a very structured way studies the outcomes along with the startups of what impact that has on clinical care and on outcomes. So I would love to see more of you working, yes, working in a scalable way, the way Qualcomm and Walgreens are, but also finding ways to partner in a much deeper way with the clinical delivery system. And you'll want to market your products directly to consumers, sure, but I just think things are going to go so much more quickly if we have the demand getting pulled from both consumers and from the delivery system. I spend a lot of time, I have a certain passion as a patient. I believe that patients are solvers, and patients are inventors, and they're innovators. And I do get a little frustrated when we see the patient as the passive, like the best we can do is involve them in the design process. Because I meet patients like my friend Dana, who has type 1 diabetes, and she and her boyfriend, who's a coder, have developed kind of a form of an artificial pancreas. They've created algorithms that push alerts to her, and she's had incredibly much better control of her diabetes in the last year. She's impatient. She doesn't have a product on the market, right? My friend Dave, who's been visualizing his own diabetes data and has hypotheses that he's been testing with his own data. I would love to see you develop products for these super smart patients. Okay, it's not everybody, but let's engage the patient in their own right as an inventor and a creator, and have products that let them set hypotheses and test them through the work you're doing. And I don't think it's just young folks. You know, I was telling some folks the story of my mom. My mom's 84. She has an iPhone, and she's taking a Greek dance class, and she films the class and replays it at home to practice. She's a neuropsychologist, right? She researches every single health condition she has and makes the best choice. So let's treat patients as these incredible innovators that they are. Finally, the last thing I just want to leave with, and this really is one of the really important and legacy points I think we've heard about over the last couple of days. We cannot let our data, our patient data, and the data that is necessary to improve the healthcare system be stuck in silos. I was incredibly encouraged to hear company after company releasing open APIs, obviously with security and with privacy in mind. But we need a more open way to look at the use of data in healthcare. And I am so excited to see business models like the ones you're having that are actually benefiting from the sharing and aggregation of data. Ellie's example of using her tool to crowdsource a data source that will be available to everybody. We're not going to get there with our siloed, broken ways of thinking about how we use data, and we need to move forward to the future. I'm going to end there. Do I have time for a couple questions or no? Okay. And if there are none, if you are eager to get to your next event, that's absolutely fine as well. And it's a little hard to see. I'm not going to share my email address, no. Oh, yeah, I do. Tweet me, Claudia Williams.
Hi,
Only because I have 3 email addresses and I never remember.
I have a question that from the office perspective, the White House of the one that you're working on, so what's the kind of policy that encourage innovation? For example, you have a certain fund, a venture capital that allocate to ask people working on the innovation on healthcare field.
Sure. We have no money at the White House. I know we have a lot of control and power, but we actually have no money. But what we do have is an incredible pen and an incredible ability to convene folks. And we have actually probably hosted 10 to 20 hackathons and data jams and challenges in partnership with our sister and brother agencies to invite both large and small companies to come together to innovate better solutions. We're also in everything from health to the environment through our regulatory and payment approaches, inviting innovation. So in the example of ACOs, of outcome-based payment, that is what is getting the marketplace to come forward with new products and tools. It's not us directly paying for the innovation, right? So we're seeing a burgeoning of innovation in healthcare that largely, I think, is coming out of the availability of digital data for the first time, and outcomes-based payments that are finally asking us to figure out how to pay for care at home and in other locations than the hospital. Okay, yes.
Yeah, one of the most expensive escalators of cost in U.S. medicine is that we don't identify patients. We use 50-year-old techniques like name and birth date and ID card, but we have techniques, some of them here on the exhibit floor, things like biometrics of various parts of the body, biometric identifiers, that could be used. Now, I know the federal government is forbidden from thinking about identifying patients, but perhaps they could encourage the private sector to start using biometric identifiers instead of relying on matching text that will never match.
Well, I agree with you completely that matching patients to their data and not making mistakes with that is a huge safety issue and is actually going to be a critical element in this kind of big data analysis we're talking about. Yes, in fact, as a result of some negotiations that came out of HIPAA, what we're not allowed to actually do policymaking on is a nationally unique identifying number. Right. We are very encouraging of others to come up with better ways to match patients and their records, including through patients having their own unique number that they might select to have, right? Just not a national, card system like you might find in Europe. Maybe I'll take one more question and then we'll.
Yep. I have a quick question for you. As you know, telemedicine has been taking 50 years or so to be even recognized as something. I only see the marketplace really changing when reimbursement will acknowledge that you can do online consultation even for phone or video or some form. So I know that there are certain things happening in the government, but I don't know how are they. Can you illustrate that a little bit more, if it's been any progress on that area of reimbursement?
I'm not sure I understood what your topic
Reimbursement
was.
for technology, because telemedicine is technology, but the doctor only gets paid when,
CMS,
having courses online to educate people for diabetes.
So maybe I'll just briefly mention the chronic care payment that Jim Malt discussed and I did as well pays doctors $42 a month for actually caring for patients, both through telemedicine, remote monitoring, and other things. I think that's a smart approach, is not necessarily paying directly for the technology, but saying what are the ways of caring for patients that we want. We want care coordination, we want adverse events monitored, et cetera. So this is a huge opportunity for folks to come forward with those technologies. Thank you so much.
Thank
Have a
you.
wonderful night.